Welcome everyone at home to the Potpourri session of the ANS program. My name is Brian Nicholas. I'm from Upstate Medical University in Syracuse, New York. I am joined today by my co-moderator, Emily Stucken from the University of Michigan. We have a wonderful program this afternoon with a group of accomplished clinician scientists presenting their important work on a wide range of neuroautologic topics. Among them is this year's Nicholas TOROK Vestibular Award winner, Stephen Curry from the University of Nebraska. Dr. Curry will present his work on the higher readmission rates after hip fracture among patients with vestibular disorders. Before we get to the program, I do wish to applaud the tremendous work of Brad Kessler, who has led the ANS through this challenging year. I'd also like to recognize Howard Francis, who has chaired this year's wonderful ANS Scientific Program Committee. And of course, though it's been said today and last evening, it really is important to recognize Kristen and Ashley, who do a tremendous amount of work for this society to make this conference go off, but with the society throughout the year. So thank you. So without further ado, let's get to our program.
Hello, everyone. My name is Vir Patel. I'm a fourth year ENT resident at the University of Pennsylvania. And today I'll be discussing a comparison of outcomes for surgical repair of spontaneous temporal bone CSF leaks and encephaloceles using bone cement and autologous materials at our institution. I have nothing to disclose. So temporal bone CSF leaks and encephaloceles may arise due to a variety of reasons, due to traumatic, iatrogenic, and neoplastic etiologies, but they can also be spontaneous. While the overall prevalence remains rare, the incidence of spontaneous CSF leaks is rising in the United States, and this pathology is often misdiagnosed initially as just serous otitis media. So it remains critical for otolaryngologists in any setting to recognize spontaneous CSF leaks as a really important cause of hearing loss, oral fullness, middle ear effusion, and clear otorrhea and rhinorrhea, particularly because this pathology can lead to more serious complications like meningitis. Now, surgical repair is key to both alleviate clinical symptoms of leak and prevent meningitis. The choice of surgical approach and repair material is guided by a number of patient factors, but also varies from institution to institution and surgeon to surgeon. But there remains a gap in our understanding of how various repair materials may affect surgical outcomes. While some retrospective reviews have shown the viability of hydroxyapatite bone cement as a good option for middle cranial fossa repairs, no study to date has evaluated head-to-head outcomes in transmastoid repair for spontaneous CSF leak with and without the use of bone cement. And so through our study, we sought to answer the following questions. Is bone cement a viable material for repair? And secondly, can the use of bone cement reduce operative time, reduce the need for harvesting autologous materials, and still offer overall sustained resolution of leak and encephalocele? So we present a single institution retrospective review of patients who underwent transmastoid repair, transmastoid approach to temporal bone, spontaneous CSF leak, and encephalocele repair, with variation otherwise solely limited to the material used for repair at the site of leak. Of note, no subjects in this study underwent intraoperative or preoperative lumbar drain placement, shunting, or preoperative acetazolamide therapy. Now, this chart depicts a breakdown of each arm of our comparison groups, which varied by repair material used. Bone cement alone versus autologous materials alone versus combined repair with both bone cement and autologous material. Now, in terms of how our patients presented, the most common presenting symptom was clear otorrhea, the majority of which were post-tympanostomy tube placement, as well as subjective hearing loss. Of note, post-hoc analysis did demonstrate some differences across the group with respect to increased prevalence of hypertension amongst the combined material subjects and type 2 diabetes in the bone cement subjects. Review of our operative data demonstrated that encephalocele was the most common finding, followed by identification and repair of multiple tegment defects as opposed to a single defect. It's worth noting here that there was a statistically significant difference in the frequency of multiple defects, attributable primarily to the combined materials group on post-hoc pairwise analysis. Intraop active CSF leak was present about 42% of the time. And importantly, the mean operative time was significantly lower when bone cement was used, including in the combined materials repair group. And this difference was maintained between all pairs on post-hoc evaluation. Postoperatively, about 93% of patients had successful repair without known recurrent CSF leak or encephalocele since surgery, with the mean follow-up of about 4 years. Importantly, there was no significant difference in success rates between the three groups we compared. With respect to overall recurrences, there were a total of 3 failures, with 1 recurrence seen in each repair method. The recurrence in the bone cement and autologous materials group occurred within the immediate or initial postoperative period, while the recurrence in the combined materials group occurred at a significant delay of about 3.5 years following the initial surgery. Importantly also, none of these subjects had undergone preoperative workup for idiopathic intracranial hypertension. So we then performed a multivariate logistical regression to assess predictors of recurrence. This demonstrated that active CSF leak at the time of surgery was the sole predictor of recurrence out of all these other variables. I think this finding then begs the question, what really is the impact of IIH in post-op recurrence? While rising rates of obesity and OSA have been correlated with increased incidence of spontaneous CSF leak, they have not been associated with the higher risk of post-op recurrence. On the other hand, elevated intracranial pressure, however, has been associated with increased recurrence following repair for lateral skull base CSF leaks. While management of IAH with acetazolamide or shunting is part of many management algorithms in anterior skull base CSF leak repair, and almost certainly plays a role in failure here, there's still not really a widely accepted proactive paradigm for its management in the pre, peri, and post-operative settings for patients undergoing lateral skull base repair. Most subjects in this study did not undergo preoperative workup for IAH, including those that recurred. The 5 patients in our cohort who had undergone preoperative consultation for IAH had negative workups. Now, given that active CSF leak at the time of surgery was the sole significant measure during the multivariate analysis associated with subsequent recurrence, it's conceivable that this finding is simply reflective of intracranial hypertension, and that a more systematic approach to evaluation for IAH would yield a better predictor for recurrence than active intra-op CSF leak. In summary, we present the largest series to date demonstrating the efficacy and non-inferiority of isolated bone cement for the repair of spontaneous CSF leaks without the use of additional allograft or autograft material. Use of bone cement in our cohort also led to significantly decreased operative time for patients as well. While some have previously advocated for middle cranial fossa approach for repair of multiple defects, we contend that with appropriate patient selection, transmastoid approach yields excellent closure rates in the management of spontaneous CSF leak, even in the presence of multiple defects. So in conclusion, there are several notable limitations to our findings, including the retrospective design, its single institution experience, and small intergroup sample size. And I do think that future work would really benefit from the development of a more systematic protocol to identify and proactively manage patients affected by IIH in order to yield valuable prognostic information for those at highest risk of postoperative recurrence, irrespective of method of repair. Thank you all for your attention.
Hello, everyone. My name is Cody Page. I'm the first-year neurology fellow at Baylor College of Medicine and MD Anderson in Houston. Thanks for everyone for being here, and thank you to the ANS for selecting our data for presentation. The title of our talk is Perineural Invasion of the Intratemporal Facial Nerve. How far proximally do we chase the positive margin? No relevant disclosures for this study. So our objectives with this study was to determine the recurrence patterns in patients with head and neck cancers that required a facial nerve sacrifice, and then to determine optimal management of these patients. So as you all know, various malignancies from the head and neck can involve the facial nerve. Facial nerve involvement is not necessarily common, but when it's present, it represents a late-stage disease. Management in the setting of malignancy is controversial. So generally, most surgeons are going to try to preserve the functioning nerve if it's possible. But if there's no plane between the tumor and the facial nerve, management will differ, with some sacrificing the nerve for oncologic reasons and some debulking the tumor with plans to treat with adjuvant therapy. As we move more proximally along the nerve into the intratemporal segments, the discussion gets a bit more complicated, as labyrinthectomy or possibly mid-fossa approach will be required if one is going to pursue the proximal facial nerve margin. And so the question becomes, is a labyrinthectomy, the vertigo, the acute vertigo, the hearing loss, the morbidity from that surgery, the possibility for CSF leak and meningitis, but for the mid-fossa approach, are these worth the risk? So we performed a retrospective chart review. We included patients with malignancies. These were various primary sites. And then, of course, the facial nerve had to be sacrificed. We were particularly interested in the overall survival of these patients, with attention to the patients who had a positive proximal nerve margin versus those who had a negative margin, and then also recurrence patterns. And so specifically, the patients that did recur in the proximal facial nerve margin group, were those recurrences proximally along the nerve, suggesting that we should follow this margin, or were they distant or local regional? So results of 155 patients over a 21-year period, median age and patient follow-up are illustrated there, along with gender and ethnicity. On the right side of the screen, a pie diagram represents the primary sites. Parotid tumors made up the majority of these. Periauricular skin, external ear, and ear canal were smaller numbers, and then a few others smaller still. On the left side of the screen is the extent of temporal bone surgery. This was dictated based on the extent of the tumor. Most patients underwent a lateral temporal bone resection, 57%. Mastectomy were smaller numbers, and then even smaller subtotal and total temporal bone resection. Most of these patients underwent parotidectomy, and then there's a handful of other adjunctive procedures that were performed and are listed there. On the right side of the screen, the pathology is represented. So most of these were skin cancer primaries, but also a large number of primary parotid tumors, and a host of other histologic types are represented as well. On the left side of the screen, the diagram represents the location of this facial nerve sacrifice, and so 78% or 78 of these were extratemporal, but then the balance of these were at various locations proximally along the nerve. On the right side, the pie diagram represents the status of the proximal facial nerve margin. And so 142 or 92%, we were able to clear a negative margin with respect to the facial nerve. And then positive margins were experienced proximally in 13 or around 8%. As we drill down further on those, looking at the actual site of the positive margin along the facial nerve, mastoid, second genu, tympanic, geniculate, and then proximal to that are represented in the smaller pie diagram. On the left side, looking again at those 13 patients, the primary site for those tumors with the positive proximal nerve margins, parotid primaries, periauricular skin, external ear canal, mastoid, and skull base. And then on the right sided table, adjuvant therapy in those 13. And so were these treated adjuvantly. 8 of them were treated with adjuvant chemoradiation as well. 2 received just radiation, and 3 had no radiation as they had previously experienced radiation. And then of the 13 patients, the primary histologic type was squamous cell carcinoma in the majority of these. Notably, the recurrence rate was not statistically significant between positive and negative proximal nerve margin patients. However, what we did see, or what we didn't see rather, was that there were 0 recurrences proximally along the facial nerve. On the left side, the Kaplan-Meier curve represents the overall survival of the total number of patients included in this study, which you'll see is a 54% survival at around 5 years. And then on the right side, we break this out between proximal positive margin status, with positive showing around 23% 5-year survival, and then the negative group showing around a 60% survival rate. And so in conclusion, patients with head and neck cancers that involve the facial nerve, in the large majority of these were able to clear the nerve margin, and so 92% in our study, and it's around this in other studies mentioned in the literature. The positive proximal facial nerve margin patient group did have a worse overall survival, but this did not correlate with an increased risk for recurrence. And notably, none of the patients in our study recurred proximally along the facial nerve. Rather, these recurrences, when they did occur, they were typically distant, but also a few local regional recurrences as well. But again, none of them were proximally along the nerve. And so overall, taken in total with what's in the literature and what our experience indicates, we do not feel that there's a routine support for routine labyrinthectomy or mid-fossa approach to clear the proximal nerve margin. References are included here, and I appreciate everyone's time.
Hello, everyone. My name is Irace, and I'm a 4th-year medical student at Columbia University applying for otolaryngology residency this cycle. I'll be discussing today the laterality of early age-related hearing loss and brain beta-amyloid. I have no disclosures. Age-related hearing loss is a highly prevalent gradual degeneration of the auditory system in older adults that involves both ears. This condition has been linked to the development of cognitive decline and dementia. In fact, recent evidence suggests that if age-related hearing loss were eliminated as a risk factor, the incidence of dementia may decrease by 8%. And while the relationship between age-related hearing loss and cognition has been widely studied, the underlying biological mechanism has not been established. This diagram highlights mechanistic hypotheses that aim to explain how hearing loss may cause dementia, including changes in cortical activity and cognitive load, structural brain changes, as well as social isolation. Possible non-causal mechanisms, on the other hand, include common underlying pathologies or confounders that may lead to both phenomena. One mechanistic possibility that has not yet been widely studied is brain beta-amyloid, a pathologic hallmark of Alzheimer's disease. Our group recently found that more severe hearing loss is linked to higher brain beta-amyloid burden. The objective of this investigation was to perform a post-hoc analysis of our beta-amyloid data, specifically focusing on differences in the relationship between hearing loss and beta-amyloid between the left and right ear. Although age-related hearing loss often affects both ears, this condition is often not perfectly symmetrical. Furthermore, each ear has slightly stronger connections to the opposite brain hemisphere, suggesting that hearing loss in each ear may be related to different downstream changes. Thus, we felt that looking at hearing loss in the right and left ear independently may provide some useful insights about mechanistic pathways. Participants were late middle-aged adults from the Northern Manhattan Study of Metabolism in Mind, a large cohort study based at Columbia. These participants underwent hearing exams and brain imaging from 2017 to 2019. The exposure in the study was hearing, as measured by pure tone average and word recognition score. Word recognition score was tested by presenting each participant with words in English and Spanish at a loudness that they should be able to hear. And then the score was the percentage of correctly repeated words. The outcome in this study was beta-amyloid standardized uptake value ratio, or SUVR. This is basically a fancy way of saying beta-amyloid signal in the brain. Participants were injected with a radiotracer for beta-amyloid and then underwent PET scans. A higher SUVR indicates greater beta-amyloid signal. And SUVR was calculated for the whole brain and specific regions of interest, including the frontal, cingulate, lateral temporal, and parietal cortices. The association between beta-amyloid signal and hearing was analyzed using multivariable linear regression for each ear. Covariates included age, gender, years of education, a cardiovascular disease composite score, and whether or not the participant used a hearing device, as these were believed to be potential confounders of the hearing-amyloid relationship. Moving on to our results, 98 participants met inclusion criteria for this study. Mean age was 64 years and 65% were female. Pure tone averages and word recognition scores correlated with age similarly to population norms, and they were not significantly different between the right and left ears. This table shows the results of our multivariable regression analysis using left ear hearing. Adjusting for covariates, a 10 decibel worsening in pure tone average in the left ear was associated with a significant increase of beta-amyloid signal in bilateral cingulate cortices, bilateral frontal lobes, and the right temporal lobe. For every 10% worsening in word recognition score for the left ear, increased beta-amyloid was observed in these same regions of interest, as well as both parietal lobes and the whole brain. Of note, however, no significant associations were observed between beta-amyloid signal and either of the hearing measures in the right ear. These results suggest that worse hearing in the left ear, but not the right ear, was independently associated with higher beta-amyloid burden. The concept of right ear advantage may be related to these findings. The right ear advantage hypothesis is centered around the finding that when adults are presented auditory stimuli to both ears simultaneously, they typically have better recall of stimuli presented to the right ear compared to the left. In most individuals, the left hemisphere is dominant for auditory speech language processing. And the right ear, as noted previously, does have slightly stronger connections to the left hemisphere. Thus, the right ear may be advantaged for sound processing, and this advantage may provide some initial resilience to age-related decline in auditory input from the right side. This is consistent with previous evidence that adults with mild Alzheimer's disease tend to demonstrate a larger right ear advantage than healthy controls. However, these theories are highly speculative and this data is preliminary, so additional studies are warranted to see how hearing loss specifically relates to beta-amyloid production. Limitations to this study include its cross-sectional design. We are not able to make any inferences about causation due to that fact. Power is limited due to small sample size and the predominantly mild hearing loss within our sample. In addition, local recruitment of patients from a single region limits generalizability. We hope to replicate these findings in larger cohorts with a broader range of hearing loss. Prospective studies would help us look at changes over time. And it would also be good to look at how these pathological changes correlate with clinical cognitive decline. I'd like to just thank my co-authors, especially my PI, Dr. Golub, for their assistance and guidance with this project. Thank you.
Thanks everyone for joining today. I'm Steve Curry, a third-year otolaryngology resident at the University of Nebraska Medical Center. I'll be presenting our work on higher readmission rates after hip fracture among patients with vestibular disorders. I'd like to thank my co-authors who contributed to this project. Neither I nor my co-authors have any disclosures related to this work. The idea for this project came from the observation that there were a lot of older patients seen in our otology clinic for vestibular symptoms who all seemed to have hip fractures. Several of these patients also had been prescribed meclizine for symptomatic treatment of their symptoms. Our project sought to investigate the outcomes among patients with vestibular disorders who suffered from a ground level fall and hip fracture, and to identify predictors of increased morbidity and mortality among these patients. We hypothesized that patients with vestibular diagnoses would have worse outcomes compared with those without. Patients were first identified using searches of categories of ICD-10 codes, including specific codes contained within each of these taxonomies for diagnoses of vestibular disorders and for hip fractures. Next, we extracted demographic and clinical data from charts of the patients in the vestibular group. There were 201 patients meeting inclusion criteria who were then each matched on age and sex with 2 patients who did not have vestibular diagnoses. Patient charts were reviewed and patients not meeting inclusion criteria were excluded for further analysis. Within the vestibular group, 60% of the patients were diagnosed with dizziness, 23.9% with vertigo, 13.4% with BPPV, and 2.5% with Meniere's disease. No patients in this group were diagnosed with vestibular neuritis or with vestibular migraine. The 2 groups were compared with respect to their baseline comorbidities and medication use, since these are known to influence falls, hip fractures, and vestibular symptoms. The 2 groups were similar in the baseline comorbidities, but with higher rates of diabetes found in the vestibular group and higher rates of dementia in the control group. The red boxes on this slide indicate which group has a higher rate of acomorbidity when there was a statistically significant difference between the 2 groups. Data on medication use within pharmacologic classes known to influence either the vestibular symptom or the risk of hip fracture were then extracted at the time that patients were admitted for hip fracture. These rates were overall similar, but the control group had higher rates of antihypertensive medication use. There are no significant differences found between the vestibular and control groups for rates of surgical treatment for hip fracture or the length of hospital stay. And no significant differences were found for disposition at discharge either. However, after discharge from the hospital, the vestibular group was found to have significantly higher rates of readmission within 30 days. No difference was found for 30-day mortality. Logistic regression was used to model 30-day readmission among patients in the vestibular group compared to controls. In the multivariable analysis, demographic and medication use variables found to have statistically significant differences between groups, and the univariable analysis were included for adjustment. After adjusting for these potentially confounding variables, the vestibular group had 3.47 times the odds of having a 30-day readmission compared to the control group. Patients in the vestibular group had higher rates of readmission. In examining the specific reasons for readmission within 30 days, we found higher rates of recurrent falls, infections, and vestibular symptoms among patients in the vestibular group. Overall, we found that the readmission rate in patients with vestibular disorders was significantly higher compared to the age and sex-matched controls. While speculative, decreased mobility after hip fracture, combined with an impaired vestibular system, may restrict participation in physical rehabilitation, leading to delayed or impaired recovery, and placing them at higher risk of further complications. This increased morbidity among patients with vestibular disorders presents an opportunity to further identify gaps and opportunities for improvement in diagnosis, treatment, and other areas of patient care. Here are my references. And I'd like to thank the ANS and COSM for the opportunity to present our research. And thanks to everyone for attending my presentation.
Hello, my name is Douglas Totten. I'm a fourth-year medical student at Vanderbilt. We'll be heading to Indiana University in July for residency, and I'm talking today about diameter-based volumetric models and how they may inadequately calculate jugular paraganglioma volume following a subtotal resection. I'd of course like to thank my amazing co-authors for all their contributions to this work. I have no disclosures. Jugular paraganglioma, also known as glomus jugulaire, is a rare neuroendocrine tumor derived from neural crest cells. Radiologically, jugular paragangliomas are distinguished from other skull-based tumors due to their high degree of vascularity, typically described as a salt and pepper appearance, and their classic presentation in symptoms is pulsatile tinnitus, conjunctive hearing loss, and occasional evidence of lower cranial nerve neuropathy. They're slow-growing tumors. However, they do have a risk of malignant transformation, and while low, it is present. Although defining malignancy in head and neck paragangliomas does remain a somewhat controversial issue. Given this risk, jugular paragangliomas have typically been managed through gross total resection. Due to the morbidity of GTR, however, current treatment options typically include a wait and scan approach, intensity modulated radiotherapy or stereotactic radiosurgery, and subtotal resection or a combination thereof. One issue with subtotal resection is determining if the tumor is subsequently grown. Ganglioma volume is typically approximated from a linear one-dimensional measurement. These tumors, however, are three-dimensional and tend to have quite a regular morphology given their location in the skull base. Thus, approximations may not be very accurate, potentially resulting in over and under treatment as growth may be artificial or missed. Consequently, the purpose of the study was to compare standard diameter-based approximations to slice-by-slice tumor segmentation, also known as contouring. Here is an example of segment. You can see the preoperative tumor in portions A, B. The tumor is encircled in B and filled in with color in C. D and E show the postoperative tumor and the tumor of the hand-drawn contour, respectively. So for this study, we evaluated all jugular paraganglioma patients at our institution that experienced a subtotal resection from 2007 to 2019. Pre- and postoperative scans were measured first through linear-based model calculations, and secondly through slice-by-slice tumor segmentation performed by a senior neuroradiologist. Our main fitness criteria was absolute percent error. We defined appropriate error as APE less than or equal to 20% based on previously published data. Bland-Altman plots evaluated reproducibility as well. 21 patients fit criteria for this study. Following subtotal resection, the APE for all three linear models, which are cuboidal, spherical, and ellipsoidal, all exceeded the established 20% threshold for viability, as we shall see shortly. The cuboidal model, the least accurate compared to tumor segmentation, overestimated bias preoperatively as well. Here you see the volumes, APEs, and biases of each of the models in these three settings. As we can see here, preoperatively, the cuboidal model APE does not meet the 20% threshold, while the ellipsoidal and spherical models barely meet it and are very borderline. Postoperatively, however, all three models are inaccurate in measuring tumor volume compared to slice-by-slice segmentation. Similarly, all three models inaccurately assess extent of resection. This figure shows the bias of each model versus the other models. As you can see here, the cuboidal model significantly and systematically overestimates tumor volume versus segmentation. In this figure, we see that the cuboidal model's APE is also significantly different from both the ellipsoidal and spherical model APEs in both the pre- and post-operative settings. However, the extent of resection is similar for all three of these models, suggesting that error pre- and post-operatively may be somewhat consistent within each model, though not between. These Bland-Altman plots demonstrate the difference between each of the three linear models compared to segmentation. As you can see, there is a wide amount of error going in both directions for most of these models. However, the cuboidal model does trend to have a overestimate rather than an underestimate, while the ellipsoidal and spherical tend to just have error as opposed to any sort of systematic over or underestimate. So compared to gold standard segmentation, all linear models are inaccurate postoperatively. The cuboidal model overestimates and is also inactive preoperatively. Spherical ellipsoidal models are also borderline preoperatively, right around that 20% threshold that we define as viable, but do appear to be within that threshold. Tracheal paragangliomas are often irregularly shaped, and a one-dimensional measurement does not incorporate growth in other dimensions, and thus growth may be missed or falsely observed, depending on the situation, potentially resulting in over or under treatment. Segmentation may be time-consuming, and it is more accurate, however, and we're hoping that in the future, automated contouring may be a solution to this challenge. Radiologic measurements are also only one aspect of clinical decision-making, and other aspects, including the patient characteristics and tumor characteristics, must be taken into consideration as well when making these clinical decisions. In conclusion, common linear-based jugular paraganglioma measurements are neither accurate nor precise. Segmentation is much more precise and may better assist decision-making and determination of need for salvage therapy. These are my references, and thank you very much.
Hi, everyone. My name is Neil Godse, and I'd like to present our work on pain and pain control following otologic surgery from the University of Pittsburgh. I'd like to thank the ANS and COSM for the opportunity to present today. The authors have no conflicts of interest or relevant funding sources to disclose. In 2017, opioid use was declared a public health emergency by the Department of Health and Human Services in the US. In 2019, over 10 million people misused opioids and over 40,000 people died from overdosing on synthetic opioids. As the epidemic has gained national attention, there's been a growing body of work analyzing factors that allow for its perpetuation. Studies have shown that approximately 10% of opioid prescriptions are written by surgical specialties and that opioids tend to be overprescribed by surgeons. Otolaryngology as a field contributed over 900,000 days worth of opioids in 2015, and prescribing patterns were found to be particularly heterogeneous. Within this context, the purposes of this study were to characterize pain following otologic surgery, quantify the use of opioids and over-the-counter analgesics after otologic surgery, identify possible risk factors for opioid use following otologic surgery, and to provide opioid prescribing recommendations following otologic surgery. The study was conducted as a prospective cohort study using patient logs. Patients were provided with a standard dose and amount of hydrocodone acetaminophen following surgery. Only patients undergoing outpatient surgery were included. Patients who required an inpatient stay, surgery with intracranial dissection, or those with baseline pain or opioid use were excluded. The amount of opioid used was converted to milligrams morphine equivalent for comparison purposes, and over-the-counter pain medication use was also tracked. These are the forms and pain logs that were provided to the patients. On the left is the demographic sheet. Here we tracked basic demographic information as well as certain comorbid conditions, including alcohol and tobacco use, and the presence of depression or anxiety that were possible risk factors for opioid use. On the right is the pain log. Patients were asked to make a log entry every time they took a pain medication and record their pain level on a scale of 1 to 10, where the pain was, associated activity, and what pain medication they took. If they didn't take any medication on a particular day, they were asked to record an overall pain level for the day. This data was then used to calculate average daily pain scores for each patient for analysis. 60 patients were included in the analysis and were subsequently divided into transcanal surgery, for example, a stapedectomy, or surgery that required a post-auricular incision, for example, cochlear implantation or a tympanomastoidectomy. Basic demographic information is also presented here. There was a slight female predominance in comparable rates of tobacco and alcohol use, as well as the presence of depression or anxiety between groups. A pooled analysis of all reported pain scores demonstrated that some patients used opioids for all pain levels on the pain scale. Patients always took some form of analgesic for pain scores greater than or equal to 6 out of 10, and exclusively took opioids for pain scores of 9 or 10 out of 10. In general, as time elapsed from surgery, a progressively greater proportion of patients experienced no pain, and the rates of medium pain, scores from 1 to 5, and high pain, scores from 6 to 10, steadily declined. By post-op day 4, 50% of patients reported pain scores of 0. Across both approaches, patients experienced significant decreases in pain scores from post-op day 1 to post-op day 5, as well as decreases in opioid use. There was a non-significant trend towards increasing over-the-counter analgesic medication use from post-op day 1 to 3, and then a significant decrease from post-op day 3 to 5. Similar results were observed when the cohort was stratified by transcanal surgery, seen here, and surgery with a post-auricular approach, seen here. We then compared pain scores and opioid use between the two surgical approaches, transcanal versus post-auricular. We found that the post-auricular approach was associated with significantly higher pain scores and opioid use than the transcanal approach at both post-op day 1 and post-op day 5. Finally, we assessed the total amount of opioid used in the post-operative recovery period by each patient and subdivided by the surgical approach. 56% of patients with transcanal surgery used no opioids at all following surgery, and 96% used less than 25 milligrams morphine equivalent, the opioid equivalent of 5 pills of 5 milligram hydrocodone. By comparison, 32% of patients with post-auricular surgery used no opioids following surgery, and 71% used less than 25 milligrams morphine equivalent. From this study, we conclude that regardless of approach, a large proportion of patients use a very small amount or no opioid following outpatient otologic surgery. Surgery with a post-auricular incision is associated with higher pain scores and opioid use than transcanal surgery. Lastly, no study demographic factor, age, gender, alcohol or tobacco use, or the presence of anxiety or depression was associated with higher opioid use. Otolaryngologists can use this information to aid judicious opioid prescribing following otologic surgery. These are my references here, and I'd like to thank everyone for taking the time to hear our presentation.
Hello, everyone. My name is Yin Ren. I'm a neurology fellow at UC San Diego, and I'll be presenting our findings on opioid prescribing patterns after vestibular schwannoma surgery. I have no relationships to disclose. So as many of us just heard, opioid prescribing patterns have been more intensely studied in the midst of the opioid epidemic. Recently, data have shown that nearly 300 million opioid prescriptions were made in 2012 and over 30,000 opioid-related deaths. This amounted to an economic burden of almost $80 billion, which is a significant portion of our healthcare economic cost. As surgeons, however, there's generally a lack of specific guidelines for prescribing opioids, which can often lead to wide variations in the amount of opioids prescribed, even for the same operation. And moreover, studies have shown that a large fraction of the prescribed opioids were not taken by patients, which creates a significant source for opioid diversion. More recently, clinical guidelines, such as the one published by our own academy, have begun to take in a more systematic approach to opioid prescribing patterns. Moreover, in other surgical fields, such as in general surgery, there's been a push to implement evidence-based guidelines to reduce the amount of opioids prescribed while maintaining patient-level satisfaction and safety. And this has successfully led to a significant reduction of 85% for opioid prescriptions after surgical procedures such as cholecystectomy. However, in otologic surgery, and specifically in neurotologic surgery, such inroads have yet to be made. This is just a collection of recent studies looking at otologic surgery. As you can see, there's still a wide variation in amount of opioid prescribed, and also a significant portion of that were not consumed by the patients. So with those questions in mind, our goal is to characterize opioid prescription patterns for patients who have vestibular schwannomas undergoing surgery. And this was a retrospective study of over 100 patients operated at UC San Diego over the last year or so. We collected demographics data as well as presence of comorbid conditions. For the opioid prescribing data, we utilized a statewide controlled substance database. And our main outcome that we're hoping to assess is the presence of additional opioid prescriptions within 60 days after surgery. So here is the demographics of our patient population. Again, over 100 patients, slight dominance of female patients. We query the presence of comorbid conditions such as the history of recent opioid use, alcohol or tobacco use, as well as pre-existing headaches. In terms of the surgical approach, roughly over a third of the patients underwent translabyrinthine craniotomy, followed by retrosigmoid and middle fossa, with a length of stay of average of 3 days. So amongst the entire cohort, approximately 20% of patients required additional opioid prescription within 60 days. And for the patients who received only a single prescription, the total amount of opioids prescribed was just under 100 milligrams morphine equivalents. Whereas those that underwent surgery and received multiple prescriptions, they received more than double, almost triple the amount of opioids overall. We found that patient-level factors such as age, gender, tumor size, or ASA class did not differ significantly between those who received a single versus those who received multiple prescriptions. However, patients with a higher BMI had a higher likelihood of receiving multiple opioid prescriptions. Furthermore, in the multiple prescriptions group, there's a higher incidence of history of alcohol or tobacco use, as well as history of pre-existing headaches or recent opioid use prior to surgery. Most notably, the type of surgical approach chosen was not significant between the two cohorts. It was not different between the two. Finally, we performed multivariate logistic regression analysis, looking at factors associated with additional opioid prescription. We found that BMI, as well as a prior history of opioid use or pre-existing headaches, were all significantly associated with the presence of additional opioid prescriptions. Most notably, the most significant predictor was the use of opioids prior to surgery, with a almost 30-fold increase in likelihood. So in summary, in this retrospective series, we're able to characterize the opioid prescribing patterns after surgery for vestibular schwannoma. Approximately 20%, which is a significant portion of our patients, did require additional prescription. Similar to some of the studies in anterior skull base and sinus surgeries, we found that patient-level factors were predictive of needing additional opioids, most notably BMI and history of headaches or opioid use, whereas procedural level factors, specifically the surgical approach or the tumor size, did not contribute to additional opioid prescriptions. This challenges some of the existing dogma that patients with smaller tumors or undergoing retrosigmoid craniotomies may be more prone to headaches or having higher pain requirements post-operatively. Finally, these are the limitations of our study. We hope that the results from this study would allow better provider education for surgeons, as well as having a jointly established pain management plan and individualized opioid use for patients and minimize unnecessary prescriptions. I'd like to thank everyone for listening.
Thank you to all of our speakers for an excellent and very informative session. There were a lot of interest, Dr. Patel, in your talk, so we'll start off with you first. A few questions regarding the postoperative management in patients who underwent repair. From Dr. Nelson, how do you determine successful repair when not all patients were leaking at the time of surgery? And from Dr. Mamikoglu, how do you follow patients after the repair? Did you check their LP opening pressure or have them followed by a neuro-ophthalmologist?
Great questions. Thank you for them. So I would say, virtually all the patients that we operated on presented with either some combination of clear otorrhea, middle ear effusion, subjective hearing loss, and or objective conductive hearing loss on audiogram, or as I said, some combination therein. So we really define success as a resolution of their symptoms on long-term follow-up. And that included otoscopic ear exam, making sure there was resolution of their conductive hearing loss on audiogram, or just resolution of their otorrhea or middle ear effusion. Many patients did have postoperative CT to evaluate the repair, but this was pretty inconsistent just based on provider preference overall. And I think you also hit on a really interesting phenomenon that we see where as to why patients may present with beta-2 transferrin positive clear otorrhea or middle ear effusion, but ultimately in the OR, active CSF leak is not always seen intraoperatively. And while this is probably multifactorial, I think the key contributor here is that not all CSF leaks are created equal. And some patients have low flow leaks while others may have more obvious high flow leaks overall. And then I think to kind of dovetail on that, to answer the other question as well. So not all patients had follow-up like LPs with opening pressure or follow-up with the neuro-ophthalmologist. But I think kind of therein lies the rub to a certain extent where we need to work to develop probably more of a systematic protocol for having these patients appropriately preoperatively evaluated by neuro-ophtho and other folks, and then potentially have them followed after as well. And I think that would probably be key in identifying people who are at high risk to have recurrence and also help manage them postoperatively as well.
Great, thank you. And also for Dr. Patel, several of our viewers were asking to address the technical aspects of transmastoid repair of more anterior defects in the epitympanum without causing ossicular trauma or allowing bone cement to be the obstacles and cause ossicular fixation. And so if you could speak to that, and I was also wondering in your study if there were any differences in location of tegmen defect and the selection of repair material.
So yeah, it's a good question. So we definitely have been successful at repairing a number of epitympanic leaks via a transmastoid approach, but I think it certainly comes down to really careful patient selection, and there's probably some selection bias because of that. But the main thing that we've kind of focused on preoperatively is making sure that there is adequate clearance between, the top of the malleus and the rest of the ossicles and the height of the tegmen there. And typically we like to see at least a few millimeters of clearance. And if it's less than this, then these patients were recommended for a middle cranial fossa repair. And then also importantly, during the transmastoid epitympanic leak repairs, we're also, critically take time to protect the ossicles by laying down gel foam over them while we're applying the bone cement and allowing it to dry and such to prevent ossicular fixation. In terms of the to Dr. Stucken's question as to where the defect is and whether that affected kind of our repair materials, I would say no. On a retrospective review, there was a few surgeons, so some of them might have had some preference over the course of the 6 years that we looked at overall, but there wasn't specifically like if it's over the tegmen tympani versus the tegmen mastoid using bone cement or not. That didn't really factor in.
Great, thank you. Dr. Kudzi, Dr. Weisskopf wonders, do you think your study was biased toward narcotic use by providing the patient with the drugs after surgery?
Yeah, I think that's a really great question. I think there's a possibility that by providing the opioids that kind of pushed some people towards using it. Certainly there is actually really interesting data that looks at aggressive pre-op counseling and how that can actually minimize pain and pain medication use in the post-operative setting. But even if that bias is present, the takeaway that we're really impressed by is that, it's still, a very large proportion of patients, 90s, over 50% for transcanal and 40% approximately for post-auricular, 45% overall use no opioids at all. So even if that bias is there, it's still a large proportion of people who don't use opioids. I think certainly it's a great point, and it's one that we hope to address and sort of hone in on in subsequent studies, looking at reduced or no opioid prescribing regimens after otologic surgery, and to see if that appropriately controls patient pain as well, or if we're getting more patient phone calls after the fact. I think it's a great point that we'd like to clarify in future studies.
Thank you. And also for both of the opioid authors, we'll start off with Dr. Kudzi. There are a couple of questions pertaining to standardization of intraoperative medications, such as preoperative Tylenol or Toradol, as well as postoperative over-the-counter medications. So was there any standardization of the Tylenol and ibuprofen that patients used afterwards, or was this left up to the patient?
So for our study, we allowed over-the-counter pain medications, so like Tylenol, Motrin, that sort of stuff. We left it up to the patient. Essentially, in our post-op instructions, we said you can use Tylenol or Motrin for most of your pain, but if you feel like you're having pain that's not adequately controlled with that, then you can step up and use the opioid medication that was provided.
Dr. Wren, was that similar in your study?
We did characterize the in-hospital, so both intra-op and immediately post-op use of narcotics and non-narcotics, such as IV Tylenol or PL Tylenol, and we did not find that to be significantly different between the two. However, we did not control for the amount of Tylenol used or other over-the-counter after they were discharged. So we just looked at the database for the amount of opioids prescribed.
Great, thank you. We've got about a minute and a half left. Dr. Curry, Dr. Sajati remarks some surprise that no one in the study had a diagnosis of vestibular migraine, and wonders, could it be that patients who were taking antihypertensive and seizure medications in fact had their vestibular migraine symptoms partially treated with those?
I think that might account for some of it, but I think overall we saw pretty similar rates of medication use between the vestibular group and the control group. I think one of the probably most likely reasons in our own population is that a lot of these patients had been diagnosed either by their primary care physicians or by the emergency department with their vestibular disorders, and I think that vestibular migraine is still not well known outside of otolaryngology.
Great. And I've got a follow-up question for Dr. Curry. What do you propose led to the higher rates of infection in the vestibular group?
One of the things, this is still pretty speculative, but we were considering that a lot of these patients either have lung infections or other infections if they're not able to participate in post-operative therapy, if they're not being able to mobilize as well and to get out of bed after they've had a hip fracture. But there's still a lot to figure out in terms of what exactly accounts for those specific issues.
Great, thank you. And thank you to all the speakers for a really phenomenal session. Next up looks like a great panel on hearing loss and dementia, which I very much look forward to. So everyone, please join us for that.